Good afternoon and welcome to Webinar Wednesday. We're excited to have over 270 registered attendees for today's webinar, which is eligible for 1 credit from the ACI. Let's get started by giving one lucky attendee a Webinar Wednesday lunch bag for answering this trivia question. Today's sponsor is headquartered in Texas. What popular soda was invented in Waco? Answer now using the questions feature on your dashboard. While you're answering, I want to invite everyone to save the date for our full MD Expo, which will be taking place at the Hilton Baltimore Inner Harbor, Baltimore, from October 17th to 19th. We look forward to you joining us for 3 days of learning, networking, and the latest advances in medical technology products and services. More details can be found at mdexposhow.com. Okay, and let's see who our winner is, and it is James Harwood. Congratulations, Jane. The correct answer is Dr. Pepper. Webinar Wednesday would like to thank our sponsor, the Korea Institute of Technology. The Korea Institute of Technology is a fully accredited online college offering biomedical equipment technology certificate and associate's degree programs uniquely designed to develop students' technological and biomedical equipment maintenance and management skills. For more information, please visit cittx.edu. Our presenter today is Bill Basic, owner of the Korea Institute of Technology. Bill, you may begin whenever you're ready.
Thank you. Hello, everyone that's out there, and thanks for joining in today. What we're going to discuss today is going to be automated laboratory. The lab is a vital part of the hospital, as everyone knows, but sometimes the biomed technicians don't really understand what the role of the lab is and how they can implement it and make it better. So I'll explain the different departments in the lab, the automation associated with the testing that goes on in the lab, and the various types of equipment, and then compliance. And then at the end, if you have any questions, I'll be more than happy to answer everyone's questions. As you can see on this slide here, we have the different types of departments, and there's probably more, but I'm listing the main ones that are affiliated with most hospitals. You have hematology, the study of blood; coagulation, that's the bleed time studies; urinalysis; chemistry, immunoassay; toxicology, that's usually in one department, depending on the hospital; microbiology, parasitology; biology, serology, blood banking, and stat lab. So I'll get into all of those here shortly. Just so you know, my background, I started off in the military as a lab tech and went to medical technology and then broke off into biomedical. I specialized in repairing hematology equipment because our technicians who was in charge of repairing them didn't get out into the rural areas that quick. And that's where I got my background from, the lab. So we'll go to the next slide. Things in the lab, first of all, obviously to make a lab sufficient, we have to draw blood from everyone. So I'm going to try to keep this entertaining and informative at the same time, because I know it's an hour long and I don't want to bore anyone. But what I'm going to do is just tell you from the very basics to everything that you need to go as complicated as we can get with it. So we have colored tubes. Each department usually has their own colored tubes. Each tube has a different process that they use. The purple tops are mainly for hematology. They contain anticoagulant in them, and it's used to test whole blood. They count. It's called a complete blood count. CBC is probably what you're used to hearing it called. It has an anticoagulant in it, and this way it uses the whole blood just to count it. And from there, I'll get into the pieces of equipment and what the equipment does with this whole blood. The blue top is used for PT, PTT, and fibrinogen studies, which is coagulations. That's usually affiliated in the hematology departments as well. This type of blood that they use for there is called plasma. They spin it down for 5 minutes and then they test the plasma to see of your bleed time studies. And I'll get into more of what that is. And then I put TED top. That should be red top. So I apologize for that. I missed it. But the red tops are spun down for about 5 minutes in the chemistry areas, and that's what they use serum for. And then the urine, they also test urine in the laboratory. It's spun down for 5 minutes, and that's to test for differentials. If you have an abnormal urine result, they'll spin it down to see what's abnormal. A lot of times they'll find white cells, which means you might have a UTI or some kind of infection, or you can have kidney or liver problems. There's a lot that can be displayed from a urinalysis. And then there are other tubes on the bottom, yellow, green, the camo, orange, and other colors that they use for various different areas of the laboratory. And here's a picture, so if you guys ever want to see exactly what testing is involved with each of the color tubes, you have that there for your own information. Hematology analyzers is what we're going to get into first. That was my specialty in the lab, was hematology. There's numerous different hematology analyzers that are out there. Right now, the #1 instrument out there is Sysmex. It used to be Beckman Coulter, of which I worked for Coulter a long time ago, before it was even Beckman Coulter. And you have Siemens, and then you have the Abbott. And what I did here is kind of wanted you to see what the cells look like. The bottom picture that you see them going through the veins there is probably one of the best depictions you can have of a cell. The red ones you see are biconcave. That's where the oxygen sits in the red blood cells over there. And that's how they measure the hemoglobin from the analyzers, which we'll get into on this lecture a little bit later. The colored cells are actually white blood cells. They're larger than the red cells. And then you see the bottom ones there where they're lined as platelets. And then they got arrows pointing to plasma, which I don't know how they figured that out, but that's kind of what plasma will look like once it's spun down. So these are different analyzers here. I put the #1 and 2 analyzer up there. The hematology analyzers that I'm going to be discussing are not going to be tabletop so much from small offices. They're going to be in large institutions. The one on the left is a Beckman Coulter. That's probably an LH750. It's capable of doing about 100 tests per hour. And the Sysmex here on the right-hand side is also used in a large hospital, but this one here is more or less a backup for a large hospital that can do probably around 30 samples per hour. The Sysmex does have a larger instrument that can do the same volume as the Coulter. What they also do is they'll take blood on every sample that they use and take a drop of blood and smear it onto the slide, and from there they'll do a differential, which is where they actually do a visual count on the blood cells. It used to be in the past where the technicians would have to count 100 blood cells, identify each of the 100 blood cells, and from there that's where the pathologist got to review the differential. We did 100 cells. These units here do 8,196 cells that they count on the differential side. I'll go down a little further. These are pictures of coagulation analyzers. You have one on the left, that's the one on the right is a Sysmex, and the one on the left, I believe, is a Siemens analyzer. These analyzers here are measured to do your PT, which is your prothrombin, and then PTT, which is your prothrombin studies, which is meaning that the patient's usually on a blood thinner, and it wants to measure how long it takes before the blood clots. And if it takes too long, then they won't do surgery on the patient, or if it's too quick, they won't do surgery. And I'll explain that a little bit further into this lecture. Here you got urinalysis, and I put some pictures up just so you can see what you see if you do a microscopic urinalysis. The unit on the left here is just a small clinic tech that Siemens has. There's also larger units that they have with different manufacturers. On the right, what you're looking at is WBCs. This is what you would actually see if you're doing a differential on urinalysis. And then on the bottom there, that looks kind of bright and looks like tiny rocks or crystals. That's actually what these are. These are crystals. Usually when we see crystals in the urine once they're spun down, that's indicative of kidney stones. So, and then on the right there, that's another crystal. This specific crystal here is calcium phosphate, and that's very indicative of a kidney stone. When people are passing stones, this is not uncommon to see in their urine. I also put a picture on the right for your own convenience just to see different types of crystal. You have calcium oxalate. That's not the only thing you'll see in urine. In urine, you'll see RBCs, WBCs, which is indicative of obviously bleeding and infection, but you can also see bacteria, which would be moving around. You can see parasites as like trichomonas, stuff like that, and then also different types of crystals, which could be indicative of liver disease. So there's a lot that can be said for urinalysis. Also, if you're pregnant or not, it does HCG studies, but not on this particular test. That's more on the chemistry side. Here we have some chemistry analyzers. These are large ones. These analyzers here do an average of, per chemistry panel, they can do probably 25 to 35 tests per patient or per sample on that. And they can have a large output, probably around 120 patients could probably be put out in an hour. And if you take that, you're looking at over 300 tests in an hour that these instruments do, sometimes even more. There's an incubation period involved with this, unlike the hematology analyzer. And before I move on any further, because this will probably be one of your test questions at the end, is these units here, although they're doing all these tests, they only need like a drop of blood to get all that done. It's not like the old days where they needed to draw all these tubes of blood from you and to run all these tests. This can be done with 1 to 2 drops of blood, and that might even be more than it needs. The reason why they draw more is in case they have to go back and do another test to verify something, or if they split it off to do specialized testing in different departments. What you're looking at here is microbiology. In microbiology, that used to be a manual. When I was in microbiology, these units actually weren't really available to us at that time. That's kind of giving away my age. But what these units do here is they grow bacteria pretty much. What we used to do is take a sample of whatever it was that we were trying to grow to determine what type of bacteria it was, and it would take 2 to 3 days. These units here expedite it up to hours sometimes, and we put the sample on an auger plate, we streak it out a certain way. There's a 4-quadrant streak that we use, and then they would grow it, and from there it'd be able to tell us what bacteria we're working with. The good thing about that is it lets the physician know what type of medicine to use to counteract whatever the bacteria is, and that gets into a whole different ballgame right now. But what I'm trying to show you here is laboratory used to be very manual. Every backup test, manual. Now everything is automated. I don't even think the lab uses that many backup tests anymore. Blood banking was all manual back in my day. This instrument that you're looking at now is probably for cross-matching, helps you do antigen studies. A lot of times if you're working in a stat lab that requires blood banking, if you get any motor vehicle accidents or any type of people that don't have time to have their blood cross-matched, we have to do an antigen study before we donate any blood to them or give them any blood. And if we don't have time for that because of the situation, the emergency of the situation, they'll get O negative blood. This here just makes sure that our testing is more accurate than what the manual testing used to be. So, and then we get into compliance, because out of all the testing that we have in the lab, and before I get into the equipment a little more, I wanted to let you know the most important thing in the lab from a biomed point of view, helping them. If you're not working on specialized equipment, then you have to understand the compliance from it. We have diagnostic medical devices. So when we're looking at the equipment, if you're going to risk rank medical equipment, the laboratory falls under diagnostic, and that's usually a 3 on the level. It's right in the middle of the urgency. They usually get PM'd once a year. The techs are the medical technicians that do the testing are very familiar with their medical devices. So when they call to have something repaired, I can assure you they've already done all the basic troubleshooting that they can. And there's probably a serious problem with the unit that would need to be done either by the field service technician on site or the biomed if the biomed is trained on that. The lab is usually inspected by CLIA or CAP. And you see what I have there, Clinical Laboratory of Improvement Amendments, and then CAP, College of American Pathologists. Either one of them can inspect the laboratory. The main thing that they look for is they look for documentation from the biomed side. And we'll go into that later on what it is that we need to document. They usually inspect the lab annually, and the biomed plays an important role with the lab. I know that I also have a service company, so we help the lab a lot with the testing here by, when I say testing, the CLIA coming in to test the lab, by documenting everything that we do on the timers, the incubators, and the ABG machines, the safety inspections, and all that. So we'll get more into what the biomedical role is. There's 2 to 3 different types of roles that you can play, with compliance being the main one. All right. So the biomedical workbook that we use in the lab, and I put workbook needed because this is what I require from my biomeds that work for me, in each laboratory, I'd like to see a notebook. And the categories that they have in there is the ABG, the blood gas, the blood warmers, centrifuges, the glucometers, the lab timers, the thermometers, and the OEM field service reports, safety inspections, and then work performed by Biomed. The laboratory is a different beast because mostly if you go and work in the hospital, and let's say you just go to a regular surgery floor, general surgery, you'll have a work order that you can leave with the front desk there, or you'll put it into your biomed shop and store it into your database and have the record there. The lab, they like to have their records, most of them, independent of each department. So if you're working in hematology, they want all their testing that pertains to hematology in hematology. If you're working in chemistry, they want everything, all their testing that pertains to them in chemistry. So, and if you're doing it in microbiology, they want it in microbiology. So some of the labs, the lab directors will let you have the entire testing just in the director's office. So it's all contingent on the relationship that you have with the lab and what their preference is. What I'd like to do is have each of the departments, they have their own book, and then I give the main book to the director, and then we have a backup book in our shop just in case anything gets lost. So there's always, and then everything's also on the data management system that we have. So the importance of this, usually when CLIA comes in to inspect, they want to make sure that the centrifuges had all the speed tested on it. They want to make sure it was proved. And they also want to see the test equipment that was used on that, because now what DNV and the Joint Commission is starting to do, they want to make sure the test equipment that we use to test the centrifuge on the spinning, and that's just an example, it's basically on all the equipment that's being used out there. They want to make sure that it correlates. So we document that on the work order. I apologize about that. So we document that on the work order. And so when the inspectors come in, they can say, all right, you use this particular piece of test equipment there for measuring the speed on the centrifuge. And then they may go off and ask you questions about your test equipment. So we'll get into the next one. COULTER principle. This goes into hematology. And this is where hematology automation started, from the COULTER principle. Mr. Coulter, who was the owner of the company that I worked for at one time, he was an engineer. He was an electrical engineer, and his wife was a medical technologist. So he came and figured this out. The COULTER principle is simple. What they do is they have normal saline, which is a salt solution, and it sits in a bath. You have a positive and a negative electrode that also sits in the bath. And in the middle of the bath, you have an aperture that has a tiny hole in it. Okay, so as the cell goes through the aperture, each cell is measured. It causes an impulse, an electrical impulse, and each cell is directly measured by its size. So the electrical impulse is directly proportionate to the size of the cell. And from there, it creates a spike, and the spike is measured in a femtoliter. And a femtoliter is a measurement of a millionth. That tells you how small these cells are. WBCs are larger than the RBCs. So in this bath here, you would have the green dots there represent cells in general. But let's say this is an RBC bath. The RBC bath has the white cells in it and also the platelets. So what it measures in the RBC bath is everything. And the reason why, RBCs are measured in the millions. So a normal count for an RBC would be 4.2 to 5.8 million per CCM. And that's how many cells is being counted every 4 seconds. And it does 3 counts of 4 because there's 3 apertures. If it's a single aperture, it does 3 counts of 4. The unit that I showed you earlier, the LH750, has 3 apertures in it. And so it counts simultaneously 3 times. So in 4 seconds. So in 4 seconds, it'll count up to 5.5 million cells. The WBCs, the normal count, is anywhere from 3.8 to 5.2 thousand per CCM. So you could tell it doesn't matter if the WBCs get mixed in with the RBCs. So obviously for the cells to go through this aperture, it uses 6 inches of vacuum on the hind side. So where you see the arrows here, the cells go through. If I want to get a little more in depth with this, they swirl as they go through. And so as the vacuum goes through, there's also suction in it from the top. So the cells don't get counted twice. So if it stays there and it swirls, out of 4 million cells, you might get 100,000 that might get counted twice. So what they do is they use a statistical formula based on that number to adjust the average count on them. But these units are highly accurate, and they're very efficient in the lab. I want to get into the platelets. Platelets are a lot smaller than the RBCs. So as these cells go through this aperture here, the platelets are also directly measured in femtoliters. So it spikes. So the unit knows if it's a small spike, it's a platelet. What these cells also do, what this Coulter principle also does, not only does it tell you how many RBCs you have, how many WBCs, but it'll also tell you the size of each cell. So if it says macrocytic, that's a terminology used, you have large red cells. If it says microcytic, that's small red cells. And that falls under your MPV, which is your mean corpuscular volume, and or MPV, which is your platelet volume for that. So it tells you the size of the cells, which we'll get into a little more as I go to the next slide. Okay, what I just talked to you about was the Coulter principle. That was counting the cells from the CBC side. That's just the count. We get into the VCS technology now. That's the differential count. The differential count counts the white cells. All right. What we used to count 100 cells in, this counts 8,192 cells within 8 to 12 seconds. So it's a lot more accurate. It's counting a lot more cells than what we did. Out of all these cells that it's counting, it's identifying 5 specific different cells. All right. It's identifying the WBCs, which falls under leukocytes. All right. But under the WBCs, there's 5 subcategories. You have the leukocyte, which is considered a white blood cell, the neutrophil, all right, and then from the neutrophil you have the lymphocyte, the monocyte, the basophil, and the eosinophil. So what makes this so important is if you get a high white count, let's say that you're at a 10, all right, that already says you have a high white count. Chances are there's an infection of some sort, all right. You can have the flu, you can have a parasitic infection, or you can have a bacterial infection. You don't know yet. We just know that there is an infection. So what this particular testing does, if you come up high on your neutrophils, that lets the doctor know that it's probably a bacterial infection. If you come up high on the lymphocytes, lets the doctor know it might be a viral infection. Okay, so if you come up high on the eosinophils, that can be a parasitic infection or an allergic reaction to something, along with the basophils that are in on there. And then monocytes falls under the viral part as well. And those are normal cells, all right? Those are normal cells that they're counting. We can get into the abnormal cells too. This will also look at NRBCs, which is nucleated red blood cells, which is immature cells. And it will also count blast and all that. So the importance of the CBC with differential, it can tell the doctor, I'm going to give you just a case study. You come in, you have some stomach cramps, they do a CBC with differential on you. You have a 10.2 white count, it says it's elevated. They do the differential. Your neutrophils are at about 82%. Okay, the doctor says that's a bacterial infection. And from there, he'll palpate your stomach, and chances are you have appendicitis. You know, so that's what he's looking at. So and that's just an example. It also depends on what you're coming to the hospital for. But these instruments are dialed in to help the doctor pretty much diagnose fairly quickly what's wrong with you. What I like about this technology here, which is still being used today on all the equipment, Coulter was the one that designed it, is right now the cells were, as I told you earlier, the cells were being counted directly. They would count 1 cell, 2 cell, all the way up to 4 million. What this VCS technology does, it takes 3 different types of technology to analyze 1 cell. It has volume. That'll tell the computer this is the size of the cell. Based on the size of the cell, it'll say like 36 femtoliters is a WBC, so it falls in there. Then it shoots RF conductivity through the center of the cell, and that does it through RF frequency. And then the laser also shoots through the cell, each independent cell, and does the scatter. And then based on the scatter, it it helps validate that the conductivity report was correct on this, as well as the volume. So from there, it can say not only is this a neutrophil, but this is an eosinophilic neutrophil, because the more of the nucleus that it has in the center there, the more light scatter it causes. And the more light scatter it causes, it's easier to identify the cell. And that's VCS technology. And before I flip to the next slide, I didn't get into the WBC side aperture. The WBC aperture also has red blood cells in it, but red blood cells cannot be counted for the WBCs. So what they end up doing is they put lyse solution into the WBC bath that hemolyzes the red blood cells. In doing so, not only do they get the white count, the actual number, the absolute number of the white count, but they're also able to measure the hemoglobin, which is the oxygen inside the blood. So the beautiful part about this is now when you're doing a CBC and diff, you're getting your RBC, your hemoglobin that lets you know the oxygen, and then your hematocrit, which is part of the oxygen too, and the RDW, which lets you know if your red blood cells are normal or if they have any variations of them, which would be indicative of anemia. So if you have a normal RBC, let's say of 5, your hemoglobin should be 15 and your hematocrit should be 45 on a normal patient. And so those three should always be in a line. Now, if you get a cold agglutinin, which I'm not going to get into that too deep, that just means there's we have to warm that blood a little extra long to get the correct indices. That's what they're called, indices on the RBCs, hemoglobin, HCT, and then you have the MCH, MCHC. But that's just to let you know how many different tests. A basic CBC can let the doctor know about 40 different possible disease states or infections that you have altogether, and probably more than that at this point, but that's just for basic knowledge. And it'll also let the doctor know exactly where to start troubleshooting alone with a chemistry panel. So here's some counts that we get from the hematology analyzer. I listed them down. So I'm just going to let you know what this analyzer can tell a doctor. RBCs, and these are the normal ranges. If this falls low, it can mean you're anemic, okay? WBCs, if it falls low, you can have some kind of bleeding disorder or a type of cancer. And if it falls too high, you can have a type of infection or also a type of cancer, depending on how high it is. Hemoglobin lets you know if you're anemic, as well as, I didn't put in the HCT on there, which falls along, should be 3 times higher. So MCV lets you know the size of the blood. So if you have macrocytic cells, it'd be 100. Now, something to understand from this, you can have people come from Canada and go to Florida in the wintertime and jump in the water, where someone who was born and raised in Florida would not get in that water. They said it's cold. That's because usually the further north you live, the higher your MCV. Your blood is thicker, so supposedly when you're up north than you are in more tropical climates. And that's actually true. It's not supposedly, it's true. This is your platelets. You got your platelet range 150 to 400,000. The reason why that's important, that can let you know if your body's clotting correctly or if you're having any bleeding problems. And that's what the instrument counts as well. NPV is the size of the platelets. On the right side, you see the differentials. You have your neutrophils here, which we discussed. 40 to 60% is normal. If that's high, it's indicative of bacterial. Lymphocytes would be indicative of viral. Now, in children up to 5 years old, if you notice they have runny noses all the time, sneeze and cough, they get exposed to more viruses. So theirs would be reversed. Their normal range would be 40 to 60% on lymphocytes, and neutrophils would be on the flip side of that. The monocytes, eosinophils, and basophils hold to be true. Coagulation results. This is the PT that we discussed about still in hematology. PT is how fast your blood clots. Before you go to surgery, this is one of the tests they run, because if your blood doesn't clot quick enough, or if it clots too quick, they won't do a surgery on you. They want to make sure that you're safe to go into surgery. The PTT, the partial thromblastin time, that lets you know your bleeding times under the medicine that they gave you, if it was heparin, Coumadin, or Lovenox, as you see on the bottom here. And the INR is what doctors also order, which is international normalized ratio. It means if you get a PTT and it's 12.2, let's say that's a normal result, 12.2 seconds, it should be the same in another lab in another city. So they just want to make sure that's the same. That's a blue top, by the way. and it measures plasma. And then you got urinalysis. Urinalysis, they test for WBCs, RBCs, crystals, protein, creatinine, glucose, parasites, and HCG. What that lets the doctor know is if you have any infections, kidney problems, diabetes, pregnancy, and it goes even further. You can go into liver problems as well on that. So it tells you a lot more than that. But I'm just giving you guys the basics. And the reason why I'm letting you know this, you may be interested in one of these areas to work on equipment. Each area is very specialized on their equipment that they use. And you can work on more than one, but it's also good to be a specialist on one specific one instead of a generalist. Chemistry and toxicology in a regular hospital are usually in the same clinic. A chem panel measures all kinds of things. That's the generic state. It covers everything. Within the chemistry panel is a liver panel. The liver panel measures your liver and lets you know if you have any liver problems, which are indicative from drinking, or it can also go from hereditary disease, fatty liver. And then it gets into more of that. If you have hepatitis, they'll do a hepatitis screen, but that's not off of, that goes into a different area there. You got your cardiac panel, which measures your AST, SGPT, and SGT, which will let the doctor know if you had a heart attack. And the good thing about that now is they got a test called troponin T. Not only can it tell you if you had a heart attack, but it can tell you when you had it. Sometimes you'll go to a doctor for a physical, not realizing you had a heart attack, and they'll pick it up and let you know. The liver panel, which I didn't get into, no, never mind, I did get into that. We'll just go to, it also lets you know the electrolytes. The electrolytes let you know if your sodium, potassium, or chloride are normal. And then it does the kidney panel. So usually if they run a urinalysis on you and there's something abnormal, they'll also do a kidney panel, which is your amylase, creatinine, and protein, let you know if you have any kidney problems. Then you have your lipid panel, which I don't know if you've ever been, we've all been to a doctor, I'm sure. They'll say do a fasting before they draw your blood. It'll let you know if you have high cholesterol, or if your cholesterol is normal, or if you need to be put on any kind of medicine. They also do thyroid studies, they do drug screens, and they do legal and illegal drug screens. So when I say legal and illegal, they can test for marijuana, cocaine, any of that stuff, but also they can test to see if the medicine that the doctor's given you, let's say Dilantin, if you have seizures, they'll give you Dilantin for grand mal seizures. They can see if those levels are normal within you. Okay, now it's testing done with one analyzer, the one that you saw. So the testings within a chemistry panel is glucose. Glucose is the measure of sugar in your blood, so it can tell you if you're diabetic or not. BUN is for your kidneys. And I used acronyms that because I'm used to doing that from being a lab tech. And then you have your potassium chloride, CK, ISO enzymes. So when they run a cardiac panel on you, they break it down into specific testing. When they run a liver panel on you, which you see ALP, ALT, they also break that down. And then they also do calcium studies on you, triglyceride, and numerous other types of testing on there. And all of these testing can be done within 10 to 15 minutes, depending on the incubation period. The technology that they use on most of these testing that they do use on chemistry analyzers is Beer's law, and Beer's law is pretty simple. You just I wrote it down right here. It's the concentration of a chemical directly proportional to the absorbance of a substance that's within it. So what usually happens is in a cuvette, each chemistry analyzers are usually in a bath of some sort, or they sit in a cuvette. So the wheel itself sits in a cuvette, and then the sample is introduced with into the cuvette with the saline that's in there, or whatever the wash solution is, along with whatever it is they're testing, because each test has its own type of liquid, and some of it might be a tablet form, but it's mainly a liquid that they mix with the serum part of the testing. So chemistry uses serum. That's just in case that's a test question for y'all. It uses the serum. It's mixed down for spun down for 5 minutes, and then they pull the serum off it to test your chemistry on that. So they shoot a beam of light through your sample, and depending on how much transparency goes through the light, they're able to tell you what your result is based on if it's glucose, it would be M-GDL. And that's the way that they measure that on the back end. So if there was just a clear solution in there, it should be 100% transparency. And then based on how high your glucose is, the transparency diminishes, and the more diminished it is, the higher the glucose result. So that's pretty much Beer's law, and it works a little bit differently with each other test. Sometimes the higher it is and the lower your result could be abnormal. So having a high result is not necessarily abnormal. Sometimes it could be normal, and having a lower result can be abnormal with some of the tests depending on what they're testing for. For example, if you're doing a PSA, which if you're past 40 and you're a male and they have to do a physical on you, then they also have to do a rectal examination on you for prostate cancer. And it's not the most comfortable test to do. But what they do now is called a specific antigen test, and it's able to tell you if you have any cancer cells in your prostate. And with that, you want a lower number than a higher number. So that's always good. So that eliminates the finger test, as we call it. So, and that's a very uncomfortable test, but it's just the more technology we have, the less invasive our procedures become. Two areas for biomeds to be effective in the laboratory. First is obviously compliance. Assist the lab with the CLIA and the CAP inspections by doing, as we mentioned earlier, making sure all your documentation is correct. You communicate with each of the lab techs or the directors in each area. The hospitals I deal with, every area that we mentioned earlier has its own director. Hematology has a director, chemistry has a director or a manager. They may have managers, and then you have a director overall. It just depends how the lab is broken down. And so that's one area to truly help. Every biomed can help in this area there. If you're not familiar with the lab, you can go talk to them. They'll be more than happy to speak with you and let you know where you can help them if you're not doing so already. Learning how to repair the analyzers, that's always good. The problem with the lab is some of them, especially in chemistry, it's on cost per test. So the analyzer is pretty much rented from the manufacturer. So the biomed wouldn't really be working on that. You can learn how to repair it when the technician comes in from the manufacturer. But in other areas, hematology, micro, you can actually go to school, learn how to repair these analyzers, whether from the manufacturer or from a school such as ours. And then you can go out there and make a difference on not only faster response times, but also reducing the cost for the hospital. And the most important thing when working with the laboratory or any department that yet is communications. When you go in there and you repair a piece of equipment and you don't communicate, the lab tech may not know what you did. So always communicate, leave a documentation there, have your own supporting documentation, and then make sure that the last words that you say, is there anything else I can do for you? I recommend that not only for the lab, but for all areas. And that's pretty much my presentation today. So if anyone has any questions, I'll be open for questions.
That's great, Bill. That's really informative. Thank you. Yeah, we have got a few questions. The first one is, what are the two different roles biomedical technicians can play in the lab?
By biomed technicians, you mean?
Yes.
Okay, yeah. One of the roles is assisting with the inspections. I moved to that slide there, helping them with their inspections and making sure their documentation's in rest. They like to see that you measured all the temperature checks, that you did that, you checked their test equipment and made sure that it was correct, and that and all the spin cycle testing was correct with the centrifuges. The other area that they can play in is actually learning how to repair some of the equipment in the lab to help reduce the budget so they don't have to have it under a service contract, or to do first call. So if it is under service contract, but you can get the unit up a lot faster than having to wait 2 or 3 hours before the technician comes on site, then you can do that. And you can always help by that.
Great, that's great. Is there automation in all departments of the laboratory?
Yes.
Okay.
Except parasitology. Parasitology, because it's kind of hard. If parasitology, I worked in a lab, you're dealing with doo-doo pretty much in there, you know. It's not the best area to work in, but it's interesting. So it's hard for them to create an instrument that can tell you, hey, I have, let's go with worms. You know, you either have a worm or you don't. You'll see that with the naked eye, and I've seen that. But where they can Parasitology, also in hematology, can let you know if you have malaria, because the malarias are in the red blood cells. So I would say yes, except for parasitology, as of right now. Except for, yeah, parasitology.
Okay, that's great, thank you. Can the biomedical technician work on equipment in the laboratory?
Each laboratory is independent to itself. It depends on, first of all, what their goal is. If like our hospital right now, they're all about cost savings, right? So if we can go in there and prove that we have the capabilities of working on a piece of equipment and the lab director feels comfortable with you, they might start you off with something small. I know right now we work on centrifuges and microscopes, and we work on some microbiology equipment. So, and they're comfortable with that. But for us to get into the hematology, they'll let me work on hematology just because they know that was my expertise, but they have to see the comfort level from our biomed. So if they're trained by the OEM or by a reputable school, then yes.
Okay, that's great. How many different departments are in the lab?
It varies from hospital to hospital. I mean, I had that screen up before. You can have anywhere from 6 to 12 to 15 different departments, depending on how intricate they are. I mean, if you go to like a Johns Hopkins hospital, they may have 15, 16 because they have specialized research departments. So, and then you can have a stat lab, which I didn't get into. Most hospitals have a stat lab that's right next to the OR. And when you have a stat lab, they'll say, here's some blood cultures, here's a CBC and Kim panel, we need this stat, which means right away. And the turnaround time on that could be within 5 minutes, instead of having to wait a few hours. So.
Okay, and I've got a question from an attendee asking, what is the difference between plasma and serum?
Okay, plasma is spun down from the whole blood. All right, the plasma, that what they, for the laboratory's sake and for automated hematology, we use plasma to measure the bleed time studies, the clotting factors for the patient. So serum is mainly used for all of the chemistry studies that we have there and the immunoassays, meaning like IgGs, hepatitis studies and stuff like that, whether you have hepatitis or not. And then the whole blood is used for the white cell counts and red cell counts and platelet counts.
Okay, that's great, thank you. And another question is, do you foresee CAP and CLIA allowing for an AEM program for low-risk equipment in the same way CMS allows for it through DMV and Joint Commission accreditation surveys?
Wow, that's a very acronymic question there. So, but it's an excellent question. I do. If we can prove, without a doubt that what you're doing on an AEM is working, and you can back that up with supporting documentation, yes, eventually I do see that.
Okay, another question is, which companies are willing to affordably train in-house and third-party biomeds? And another part is,
pretty much all of them
provide everything needing to do PMs and repairs.
I've had no problems with any of the companies to do that. It comes to a couple things. Here's the trick, and I tell every time I work with a hospital, when the hospital's in the market for looking for a new analyzer, that's the best time to negotiate. The hospital can negotiate a service class for each piece of equipment they buy, regardless if it's lab, radiology, or anything. So it's the biomed's responsibility to make sure whoever is in charge, or if they're on a committee, to make sure that they negotiate the school with that. I highly recommend that every time anything's purchased.
Okay, great. Now, can a chemistry analyzer be considered as a robotic spectrophotometer?
It could, if that's what it is. So, but we do have the they use spectrometry in chemistry, by the way. I didn't get into that, but that's Beer's law through spectrometry. And some of the analyzers have the auto robot systems that you put the blood on. So in other words, when you draw it, you accession it, and it goes to a robot, and the robot takes this blood sample to each of the chemistry or each of the analyzers in the laboratory without having a technician to have their hands on it. It can be all automated.
Okay, that's great. So who are some of the good service part suppliers in the lab space other than the OEMs?
You're talking about like a third-party company that does that? I'm not sure of any third-party companies out there. My main discussion right now was mainly to have the biomeds themselves do it in-house. I'd have to do some research on that to see what third-party company laboratories are out there that do that. So, and the reason why they used to have them, but as technology evolves, the sophistication of these units have a lot of proprietary information. So to be a third party, they look at you as in direct competition. But if you're working as a biomed specifically on the hospital that you represent, they don't look at that as competition. They're more willing to give that type of person, that service professional, the information they need. Again, that goes with the negotiations of purchasing the equipment.
Righty-ho. And did you say your company trains on lab devices?
We do, not on all of them, on some, yes.
Okay, he's saying, he's assuming you're more affordable and provide certificates a manufacturer would accept if needed for parts and supplies.
Well, absolutely. I mean, we don't sell parts and supplies because we're a school, all right? But what we're trying to do now is a paradigm shift in the industry. There's a thing that the manufacturers need. They need qualified individuals to work on their equipment, and it's cheaper for them to have a partnership agreement with the hospital where the biomed does first response, and then anything major, their field service engineer can repair. It saves the hospital money and it saves the manufacturer money. I've done a study on this with TSTC a few years ago. Beckman Coulter was willing to give them their equipment, their entire curriculum to teach on how to repair that. But the state, not the instructors or anybody at TSTC, it's a state operated school. They had too much bureaucracy involved and it's never panned out. But that's where we're trying to go again, to have them donate curriculum to schools, institutions like ours and other ones throughout the country to give this training to the students.
Okay, one more question by the looks of it. Who are some of the good aftermarket part suppliers in the lab space other than the OEMs?
That varies. I know what they were a few years ago, but it always changes because companies are buying up other companies. I would have to get back with that question, and I would make some quick calls on aftermarket part suppliers. There used to be a company called Excalibur. They were pretty good in chemistry. I know they sold, but I think they're still called Excalibur. They're out of Reno, Nevada, and they sold parts on chemistry analyzers, mainly Hitachi's. But best thing to do is Google whatever medical device it is that you're looking at. If you're looking at a Hitachi or a Beckman, and type in, third-party providers or part providers, and you can get your information that way. And I'll do the same, so I have that information for the next time I do this presentation. That was a really good question.
Good. Let's see, I think that's about rounded up questions, Bill. So if anybody has got any questions they would like Bill to answer, his email address is bbassuk@cittx.edu. I'm sure he'd love to hear from you. So thank you, Bill, again for a great and very informative webinar. And obviously, thank you again to today's sponsor, the Korea Institute of Technology. One lucky attendee will win an Amazon gift card for completing the post-webinar survey, which will appear on your screen shortly. You must complete the survey to obtain your certificate of attendance. For more information about our upcoming webinars, please visit our website, webinarwednesday.live. Thank you once again for joining us. Enjoy the rest of your day, and we hope to see you next week.
Thank you so much. My pleasure.